No, I do think it's one of the ironies of my career to be an AP only giving grand rounds to a Department of Laboratory Medicine. We do have one token anatomic pathologist here, and I've known more than one. Anyway, I've known Charlie for all of my career. First of all, I want to say it's really a humbling honor to present grand rounds here at the University of Washington. I actually have very strong family connections to this place. My great-grandfather was the first eye, ear, nose, and throat physician to come to the great Northwest. He brought his subspecialty to Alaska Way when it was still mud and boardwalk in 1902. My great-grandmother was a suffragette in the early 1920s parade in downtown Seattle. Their daughter, my mother's aunt was founding member of the Department of Physical Education at the University of Washington, and my mother's cousin, whom I will pay a visit to after this grand rounds, worked in the Department of Surgery for her career and was the first in the world to purify and crystallize carboxypeptidase A. So it's a real pleasure to spend a day at the University of Washington. So going back to our table conversation about clinical laboratory being where it's at, with the residents today especially, you know, the onus is on anatomic pathology to show the value that I'm going to talk about in clinical pathology. And we could talk long about, you know, where I've put my career to try to be an outstanding liver and GI pathologist, and I still believe firmly in that. But I think as the world turns and decisions are made about the fates of the commodity that is pathology and the clinical laboratory, the challenge is before us to prove our value anew. And I'll be giving you examples from Northwell, but I'm actually going to give a fairly lengthy preamble, in fact more than half the talk, about where we are right now and why I feel such a strong sense of urgency to press forward. So first of all, for disclosures, I'm on the Scientific Advisory Committee for a tech spinoff from the nearby Cold Spring Harbor Laboratory, and also in the president on paper of the joint venture we have with BioReference to deliver precision medicine to Northwell, both of them unrelated to this talk. So questions which I will answer at the end of the talk is, what is the future of pathology and laboratory medicine? How can we, as leaders, shape the practice of pathology? And by the way, every single time I mention pathology, it's shorthand for pathology and laboratory medicine. How can we maximize its value, and what is the role of innovation in this context? So, to use a terminology which I'll elaborate on, we will define our stakeholders in a moment, but let's declare laboratory value statements for our current stakeholders, and let us take as a given that we are a commodity. We provide diagnostic testing services where the definition of a commodity is if you can do it, someone else can do it, and there's no difference between one or the other if the quality of the product is the same. And we have long since achieved, with rare exception, the requisite accuracy and reliability of lab results, and certainly lab medicine, absence of error, to qualify for being portable and negotiable. Things that fall into this as well are timely resulting. We know how to do this, and this is pre- and post-analytical, not just the analytical. And we are experts in what we do, which means not only can we deliver reliable results, but we can advise people on what they mean if we're given opportunity. We also need to have functional information technology, and this is at the transactional level, which is simply you can take your results and get them to the right place. And we forget access of patients to our services at our peril. As our networks move further and further out, blood can be moved, but you have to make your phlebotomy services available to the patients on a convenient basis. And this is a differentiator in the market. At the very least, these cannot be pain points. You cannot have letters to the CEO of your organization complaining about any of these things in your portfolio. But if you do all of these well, you are silent, you are unappreciated, and you can be commoditized. Sorry to be unpleasant, but I will call this the 1.0 version of laboratory services. So what distinguishes you from another laboratory who would prefer, who would present themselves as the preferred provider. For payers, it's cost per test. I'm sorry. Certainly in our market, and I haven't learned of differences elsewhere, the value of a lab test is the cost per test. It's not the total cost of care. It's not the total per member per month. It is the cost per test. And this is applicable in the ambulatory market. For the most part, the payers basically delegate all of the in-hospital costs to the DRG system. And so you're not exposed there except to your local hospital administration, who of course want to cut the pricing, cut your expenses. The ability to report your lab data as a quality report to the payer is actually one of the differentiators for the commercial labs. The fact that the commercial labs want your data as part of their being the providers of, the laboratory providers for the major plans, they're simply transmitting all the data to the payers. And the payers are using that data to rank and the quality of the provider organization, and quite honestly to steer patients to those organizations they deem the most appropriate. And contrary to what they say, the primary determinant of the quality or the preference of a provider is the cost of providing care to the patients. Quality is part of it, but the differentiator between Tier 1 and Tier 2 is the fact that if you cost more, you're Tier 2. To health system leadership, stakeholder group number 2, under the DRG payment system, your value is an inverse of your cost to that organization. And if, as is true for most CEOs in the country, there is an offer on the table to sell your laboratory, at least the ambulatory laboratory, to a commercial lab, some CEOs and CFOs will have already booked that information. They will have already said, this is good, I can balance the books this coming year. And it's going to be awfully hard to sway their opinion. For those who really don't want to monetize their laboratory, while its value appears to be dropping with the PAMA cuts coming, currently there is all too limited evidence for them to say, here is the value statement for keeping my laboratory in system. That evidence base, for the most part, doesn't exist because we haven't built it for them. And so they have absence, yin and yang. Sell your lab, keep your lab. Yes, the medical staff love the lab, you love your laboratory, but can you justify financially retaining it when reimbursement for laboratory services is going to drop by almost 50% over the next 6 years? And there's absence of information currently for health system leadership on that point. For providers who are your friends, your expertise at every hour of the day, their access to you, and yes, your turnaround time, are tremendous assets that you have in play. And I'll speak more to your in-system assets later in the talk. And for patients, the benefits designed for their plans has very sensitive price points for what patients consider to be a painful experience with a lab. The first painful experience is interacting with a phlebotomist. If you do not have a good patient service center, that's not going to be in your favor. And if they have copay for you and they don't for a competing commercial laboratory, game's up. So you have to be in the benefits design part of your interaction with your payers. Because if your benefit design is not favorable against the market, it's going to be awfully hard to convince the consumer that you're the preferred laboratory. I've already mentioned convenience to access to draw sites. So how do you develop the evidence base that your laboratory should be the laboratory of choice in your market? And I apologize, but I will say this is how I'm presenting my talk. It starts with financial outcomes to the payers, to the health system stakeholders, to the consumer. And you have to be mindful of that. The patient outcomes, something we firmly believe in, which is the patients actually do better health-wise for our having been their laboratory. How can we prove that? How can we prove that us being their anatomic pathologists, their molecular pathologists, their transfusionists, et cetera, that their outcomes, whoever is looking at it, the plan, the health system, or the consumer themselves, that their outcomes and their experience are better because you're their laboratory. The provider experience, again, your friends, do not be a pain point. Hopefully you are one of their favorite parts of the system. And then I'm going to give quite a bit of discussion in the last part of the talk to how the laboratory can help with the health system's approach to quality metrics, ratings, and potentially brand and reputation. So I was commenting prior to getting started that it was an April 2015 meeting that I was at for a consortium of laboratories that's called the Compass Group, thecompass-group.org, where I was sitting in the audience listening quite simply to Khosrow Shaharbani, who's now CEO of TriCare Laboratories, and he sort of gives fire and brimstone talks. And I was sitting there and saying, oh my God, we are here. And I came back home and convened our most senior laboratory service line leadership and said, we need to be there. The immediate question is, what is there? And simply put, we spent 3 days a week, 1 hour for the next 6 months trying to figure out what there was for our laboratory. It was a fantastic time to do this, but that was really our retreat. We gave that much commitment to trying to figure out where our laboratory needed to be and how we would get there. And out of subsequent discussions at the level of Project Santa Fe, the terminology of Clinical Laboratory 1.0 and 2.0 was born. Along the way, we realized that our culture needed to be formalized, and we are this. We are intrusive. There is not anywhere in the health system that we won't stick our noses if we think lab can be of value. And we are insistent. We're not going to let people deny us access to places we think you can contribute. We try to be creative. We are willing to take risks, and we also feel we need to be relentless. So these are adjectives that we're applying to ourselves. I think it's necessary to do this to sort of convince people who don't otherwise think that laboratory can provide leadership. So again, as part of this retreat over the months of 2015, what should we prioritize? And these are what we came up with. Follow the money. For one thing, how do you fund an informatics group? I see a smile from one of our residents. How do you justify the investment in a pathology informatics group? You have to attach it to some sort of financial return on that. And in our health system, that has to be a financial return within 1 year, and if you're lucky, within 6 months. And so we immediately began deploying our then embryonic informatics group on revenue cycle initiatives. We have learned in the years since that there is tremendous value that laboratory can bring to the current system of value-based payments, risk adjusters. We have not yet been able to track this to the total per member per month, but I have prior experience from the University of Florida, which is published, on the fact that laboratory-led wellness programs can keep patients out of hospitals with diabetes and can reduce the total per member per month. And as soon as the program is shut down, the hospitalizations go up, the cost of care goes up again. We haven't yet been able to address to our satisfaction leakage out of network, but that's another area to go. And yes, if you can be a driver of market growth, which is something that Washington has strong opportunity for and has been doing for years, that also helps. And in the end, it's your continued justification that you are a favorable contributor to health system financial benefit. It's nice to care for patients, and we found a very target-rich area in identifying gaps in care, particularly in the care management space, risk identification, escalation of care, and then in individual programmatic initiatives. So can we change this algebra, actually be a clinical lab 2.0? And for the payer, in the end, that's having evidence to put in front of them that you can inflect their curve and reduce total per member per month cost, that you are an instrument for improving the quality of care provided by the organization you serve. Health system leadership, I think the challenge is there. Can you demonstrate that there are actually better patient outcomes? And you have to do this on a programmatic basis. Financial benefit I've already mentioned, and quality outcomes I will discuss a bit later. For providers, again, this is your strongest asset. It is precisely because you are an in-system lab that you have the clinical collaborations and the clinical champions to drive shared leadership programs for better patient outcome. And for patients, I've already mentioned benefits design and gaps in care. I do think that there's a place for precision medicine, but it's going to take some effort to show that that maps back to total cost of care. So in the end, better financial outcomes, improve revenue, lower cost services, and et cetera. For clinical, to me, the real challenge is, can you prove that your laboratory is improving patient outcomes? And my premise is you have the advantage now, leverage it so that when decisions are made regarding your destiny, you have a very strong hand. It's hard to do this, actually. In a world that's measured by billable lab tests, you're a commodity, and payers currently define us as cost per test, and we cannot walk our efforts back to population health because we are not the effector arm of care. We impact care, but we are not the ones actually making the decisions. And so you have to have these clinical collaborations to get attribution. And moreover, as I've learned in my own health system, when you claim that you've reduced lengths of stay or total DRG costs or what have you, my own COO says, Jim, I can't spend the same money twice. The hospital's already claimed that for their other programs on these same patients. And lastly, because the current system has the payers shifting risk to the decision makers, who are the patients with their copay, the health systems with their managed care contracting, meaning are they going to defend you when the health plans come and say, we're going to have LabCorp for us and we're going to have Quest for someone else? Will your managed care stand up and say, no, our labs have to be in-house? You can't not be in the managed care space in your own health system. And your physicians, again, are your strongest defenders. Educating these decision makers on the value added for lab is part of what we need to be doing. And it's interesting, one of my favorite authors in the lab medicine space, Christopher Price, wrote this article in 2014 where in the abstract he talks about why lab has not generated the evidence base for our own value by saying there's a disincentive to generate the required evidence because our system is simply aligned with cost per test. So a diagrammatic way of looking at this is we've lived our lives in clinical lab 1.0 where the stakeholder interacts with the lab, and for the moment let's call the stakeholder a provider. The provider makes the decision and we get outcomes, but the lab is separate from those outcomes. And the advantage I think that we have to play as we do Clinical Lab 2.0 is to work directly with our stakeholders, quite honestly to provide the leadership for the programming, because the stakeholders are exceedingly busy at 12 minutes per encounter with patient to be able to keep the broader view, whereas we are seeing all the data, and to work with these stakeholders to affect both outcomes and to learn from where we fall short. So following this walk across the parking lot with Khosrow, following his fire and brimstone talk, and Khosrow saying we have to do more, and I said, how about forming a group? And with invitation, these like-minded laboratories were invited. We got together, and since Khosrow organized the first meeting out of Albuquerque, he chose his favorite spot, Santa Fe. The name Project Santa Fe was chosen. This is a photograph from our second year when we met in the Banbury Center in Lloyd Neck, Long Island. And long story short, the concept of moving from a transactional lab which provides sick care to an integrative lab which leads health care and provides leadership for risk management programs, wellness programming, and gets into the predictive analytics of healthcare. That's what Project Santa Fe was formed to do, to drive pilot projects, to try to provide leadership to a national community of peers, and to overtly attach that to the economic valuation statements of laboratory-led programs. That's our goal. And I'm not going to go through all of these line by line. You can look at it in the paper. So we brought this through an abstract mechanism to the Association of Pathology chairs in 2017. July, we were put on a panel for Friday. We said whatever we said, and at the end of it, the esteemed Jay McDonald got up to a microphone and said, Jim, this is nothing new. People have been talking about this for 25 years. And he's right. One of my favorite articles, I told you one of my favorite British authors, well, this Senard and Morrow paper in Human Pathology in 2001 is a very significant article. This very pathologist-centric view of the universe was what was presented. And it was only a few years later when I was the only pathologist in the country attending the patient-centered medical home revival meetings in Washington, D.C., that I saw their version, CMS's version of the universe. And the patient's at the center, that's great. And you've got provider and community in the first circle out, and that's great. Radiology and laboratory medicine are in the outer darkness. They are over at the edge of the CMS version of the universe of healthcare. And so it's a complete inversion of what Senard and Morrow were presenting. So my response to Jay was, we have to do more than talk. We have to act. If we haven't acted before, we must act now. And Project Santa Fe is trying to be part of that process and to provide leadership. And give credit where credit is due. I mean, there are others thinking in this space as well. The group that David Lewis convened, putting out a couple of papers in archives, and their approach to driving computational analytics. And in this paper, the appendix, to the best of my ability, gives credit to all of the folks who've moved into this space with peer review publications. It's a good list, but it hasn't turned the tide yet. It has not been influential to the decision makers at the C-suite level. Again, give credit where credit is due. When we met in 2016, these were the demonstration projects that were currently in play at the members' gaps in care, identification and tracking of pregnancies in the 90% penetration of the ambulatory market that TriCare has in New Mexico, where 40% of births are on Medicaid. And just adequate prenatal care reduces the likelihood of a NICU admission for a diabetic mother by 30-fold. And the program pays for itself on the basis of avoided NICU admissions and first-year costs for the children. I'll present very briefly our data on acute kidney injury in Northwell. Kaiser Permanente, stock and trade is the latency of laboratory data, and so on. So I will give you the Northwell version of what we're trying to do here, and hopefully there will be some ideas that are of use to you. So it's hard to sort of get your head around Northwell until you're there. There are 7 million people in the downstate New York market. Our laboratory touches 2 million unique patients per year. We have 22 hospitals, and shown here in red, it's actually now 600 practice locations, and skilled nursing facilities, ambulatory surge centers, dialysis, urgent centers. It's a very good place to be putting these ideas into play. Hospital admissions represent 27% of all patients admitted to hospital in the downstate New York market, and we have, by our estimate, 9% of the ambulatory market. The network of laboratories is shown here. The green labs are the in-system hospital laboratories. The blue are a series, the light blue in the lower right, are a series of Brooklyn hospitals that at the state's request we have taken into our management because they were distressed laboratories and the state wanted them to be part of the Northwell Laboratory Network. So we run them with our own employed chair and administrative directors, and they're an obligate part of the Northwell Laboratory Network. In April of 2014, we formed a joint venture called Colony, Core Laboratory of New York, with the Health and Hospitals of New York City, which is all the hospitals of yore, Bellevue, Elmhurst, Woodhull, the famous hospitals of the New York region, and the largest charitable hospital organization in the country, second to LA. And at state request, again, we took over Coney Island Hospital as well. So the light blue all around are non-system hospitals, which we run. And together, that rolls up to a single reference laboratory, which is a Northwell lab, and the joint venture basically is a co-op to derive benefit first through scalable volume, which is both a procurement savings as well as a efficiency savings, so that Health and Hospitals gets about $25 million per year benefit out of this, and Northwell gets about $15 to $20 million per year benefit out of the efficiencies realized by combining our cells. 2 slides of finances, which I give permission to be in the permanent record. I don't forget for a minute that we're on the hook for the cost of laboratory services in our hospitals, so that since my arrival there and creating a virtual laboratory network consisting of 17 hospital-based budgets, 1 core lab, and 1 department, so it's 19 budgets rolled up into a virtual business. We track the cost of laboratory testing, diagnostics in our hospitals with explanation for every variance, whether it's a hurricane or growth in cancer services or cardiothoracic surgery or what have you. These have to be justified to any and all, ultimately the Board of Trustees. We have certainly been favorable to the health cost index, and again, through both procurement as well as in-system efficiencies, are able to achieve defensible cost management for DRG-based laboratory testing. And the core laboratory has grown at the rate of about 20 to 25% per year. The red line is volume, and the blue is the annual net revenue for the laboratory service line. I'm not showing the contribution margin to the health system, but it's gone up tenfold in very meaningful numbers for the health system. So this is important. Boards of trustees and CEOs and CFOs care about this. But for the remainder of my talk, I'm going to be talking about value statements that, to the best of our ability, we've been developing. And to me, this is an inadequate portfolio. It has been enough to this plus the finances have been enough to justify our continued stature within our health system. But it is not enough yet to get in front of payers. And I'm very anxious and feel a strong sense of urgency that we have to build this portfolio much more to have the necessary evidence base to put in front of payers. So my baptism in informatics was thanks to a first-year medical student, Travis Doring, who was a college computer science major, ultimately orthopedic surgeon, who came to me and said, I want to do a summer project. I want to do something with data. You've got data. And I and my vice president bored him stiff for about 15 minutes talking about how he could do quality analytics. And he said, I want to do something closer to the patient. And I said, well, how about alive or dead? He said, that's good. So thus was born an analysis of whether our critical value set points were of any value to our health system. The basic idea is, can we look at critical values over a 5-year period, this was his data pull, to determine whether our critical values were saving lives. The answer to that question is we could not demonstrate that. We could not demonstrate that a phone call from the lab made at potassium of 6.2 saved lives relative to absence of a phone call at potassium of 6.1, not in any example of a critical value. What we did demonstrate is that only one critical value was set properly, and that was potassium. And the others were either too conservative or too liberal. But the one that really took my breath away was lactate. You can see a very robust data set, and the lactate was the one that really was dramatic, because shown here is the 48-hour survival curves for patients with lactates, almost always drawn in the emergency department, and the various buckets that Travis and I put them in. And you know, if you had a lactate greater than 5, your chance of being dead within 48 hours was 12%, and your chance of getting discharged dead was 40%. We didn't segment this. This was all in. Could have been head trauma, could have been sepsis. We didn't try to do that. But considering that even having a lactate drawn was a bad prognostic indicator, it turned out to be a very important test. Simultaneous with what we were doing, the health system had decided that our 1.56 rating, more, whatever, the term is, against a benchmark of 1.0, our mortality from sepsis was 1.5 plus, unacceptable. The Sepsis Initiative was begun, and so while Travis and I were trying to figure out what to do with our data, the Sepsis Task Force was looking at system data to determine how to identify patients early with sepsis and what to do about it. And the amazing thing is, just as we were concluding that lactate was a really bad analyte to have out, they were concluding that the single most important thing that could be done for a patient with sepsis was to think of ordering a lactate, because it was a proxy for thinking that the patient might have sepsis. So the sepsis bundle of order lactate, pull blood, start fluid resuscitation, and begin antibiotics lowered the mortality from sepsis by 50% over a year. So even though we weren't causally related, it was actually very nice companion validation that the informatics was of merit. So I'm going to tell you a current story. We have we have Beckman BACTEC machines for the 10,000 blood culture bottles that we receive per month. And in April of 2015, a laser meniscus reader for the bottles at 96 hours negative came operative, so that you could actually tell what the fill volume of the blood culture fill bottles was for the negatives. Doesn't do it for the positives because you've already pulled them from the machine and done a gram stain and moved them forward. But the recommended volume is 8 to 10 mils, but 3 to 10 was permissible. So we started reporting this out in June of 2015 for all of our system hospitals. And you can see, actually in April of 2015, that our system average over at the far left, the bright green red line, system average was 3.3. This does not point out that the plurality of bottles had less than 2 mils of blood in them, and a substantial minority had less than 1 mil of blood. The old literature from the glass bottle era, which I've read myself, documents that there's a 30% false negative rate for bottles that have less, for these size bottles, that have less than 3 mils in them. And they didn't even study below 3, they rejected them from the study. But if we take 30% false negative for 3 mils and below, and our system average is barely over 3, that's not a good prognostic indicator for identifying patients with bacteremia. And so we began an educational campaign, and it's been a long road. But over 2 years, we have gotten the average up to actually above 7 now. It is a quality metric for every single hospital in the health system. And this has been an extensive, multidisciplinary, and more importantly, interprofessional educational campaign with feedback through every CMO and CNO in the health system. And I will show you some results, and this is being prepared for publication. The positivity rate from the start of our campaign, January to June 2015, to January to June 2017, has gone from just shy of 7% to about 8.3%. That represents about 300 additional positives per month, which is 3,600 patients per year that have their bacteremia identified. And moreover, not shown here is that because there's a larger inoculum, on average, our bottles turn positive 16 hours sooner. And for patients with severe sepsis, the mortality rate in a New England Journal of article in 2017 is 4% per hour. So this is real stuff. It goes back to the lactate data. And another interesting finding is, thanks again to the increased inoculum, the contaminant rate has gone down from 29% to 23%. So this is real forward movement. And in terms of building value statements for why an in-system laboratory is important, this is good stuff. And moreover, it is better patient care. We haven't mapped this to length of stay. We haven't mapped this to mortality. That can be done. But this has been an all-system campaign in which laboratory is providing the leadership. We brought a new hospital into the system, major hospital in Brooklyn. Started reporting in September. This is their histogram. And you can see their average at the bottom, their average bottle fill is 3.6, but that really doesn't tell the story. These are the bottles shown in the upper that are 0 to 1, 1 to 2, and 2 to 3 mils of fill. And the head of ID, when shown this data, said, I was taught just to blush. Take your butterfly, make sure the bottle turns red. This is the first bottle, by the way. This is not the second bottle. which gets less than a blush. So that campaign is ongoing. So before you do mass spec and BCID, this is pre-analytical stuff that has huge impact. So second story, acute kidney injury, and this has actually been told at the national level, and I apologize if this is a repeat, but in the literature, which is actually very strong out of the United Kingdom, acute kidney injury affects 5 to 7% of all hospitalized patients, all comers, community acquired or iatrogenic. And the majority of patients with AKI are cared for by non-nephrologists, and as our data will show, not recognized as having AKI. And so if acute kidney injury occurs, even if it's level 1 as opposed to 2 and 3, where 3 is acute tubular necrosis, there's a 60 to 30-fold increase in hospital mortality, increased length of stay. There's also increased risk of need for renal replacement therapy, and the hospitalization costs go up. So there's an estimated $10 billion in play for unrecognized AKI in the United States. And what we instituted at the instigation of the chief medical officer of one of our busier community hospitals was a delta creatinine program, alert pilot program, but this was not clinical decision support. It was not, just a little thing popping up for the clinician. It was a CMO-sponsored 7 a.m. printout, which was sent to every nursing station in the hospital, identifying the patient by bed who had an AKI alert, which is, and the criteria are shown, either a 50% relative rise or a 0.3 milligram per deciliter absolute rise in 2 successive creatinines, with requisite eyes-on rounding on that patient to determine whether this was pre-renal or true acute kidney injury. And it was initiated, and the amazing thing is it triggered 40 times per day, over 5,000 times in 6 months, and with clinical rounding, it was clear that there were 20 patients per day who had not otherwise been recognized as having acute kidney injury. So with this representing 8% of all admissions, just staggering numbers. And so with this as ammunition, we took this to the chief medical officers of our health systems, who immediately said, we need to do something about this. And so what amounted to the pilot period, which was using the prospectively but no education 6 months of data at Forest Hills Hospital, and then retrospectively collected data from all of our other system hospitals, January to June was absence of intervention, where blue at a 21% trigger rate, give or take, was the laboratory trigger, which was intentionally set to be sensitive. And the green is the documented AKI in the discharge DRG, which was coming in around 5.5%. And then in 2 successive years, and we used January to June to make sure we had apples to apples comparisons, is shown the fact that the trigger rate has been constant in our health system at around 20 to 21%. But the clinician documentation of AKI in their patients has gone up, and moreover, the incidence of acute tubular necrosis stage 3 has gone down. Not by a lot, but given the large numbers of patients, we have 450,000 patient admissions per year. That's a lot of patients with acute kidney injury. And what we're doing right now is we're connecting that to the antibiotic stewardship program so that we can track nephrotoxic drugs, particularly vancomycin, through this to see if we can actually turn the tide of the trigger and not just the documentation. So when all was said and done, the documented capture rate has increased system-wide from 7.4% to 12.9% to, and actually it's not on here, should be to about 14% in 2016. And the interesting thing is, and this is something that Tarush Katari and I have discussed at great length, there's Tarush, it's not about money, it's about patient care. But documenting the economic impact is important. Just documenting this comorbidity has been worth $2.6+ million per year to the health system in DRG collections. And that's meaningful to the people who hold our leash. But I do take comfort, and this is in the paper that we've just submitted, that there is published data both for AKI and for sepsis that if a clinician recognizes the condition, they're treating the condition. You can't do one without the other. We've not been able to demonstrate that yet, but our pharmacy MedRec initiative, I hope, will finally be able to answer that question. So, these were, in essence, the foundational elements for establishing our, the proof of concept for establishing our division of pathology informatics, which was a single recruit in 2013, and that was Tarush Kotari. I said, make your own job. Find stuff to do. And he did acute kidney injury, which you see the data here. I'm not presenting other projects in coagulation management and antibiotic stewardship. It now numbers 10 people, 2 MD level faculty and data scientists and project managers under them. It works intimately with our LIS team. The second recruit, a more senior one, Tylis Chang, is Vice Chair and Chief Medical Information Officer for the laboratory service line. With Tylis's leadership, we've built a laboratory data warehouse. And the next slide will show the integration. But the return on investment was within the first year. It was actually within the first 6 months. It was a revenue cycle initiative. And the curious thing is, although the lab has benefited from the pathology informatics division in a material fashion, by far the greater return on investment is at the level of the health system. And in a separate discussion, which we've had on the side, I don't have time for now, how do you justify your existence when the benefit goes to somebody else? You got to walk it back. This is a schematic, at least of how I see our data environment, and I doubt other health systems are terribly different. Even if you have a single single electronic health record, there are a lot of things that need to be connected. And one of the things that must be connected to whatever health system you're using, and I'm connecting all of this back to our self-built laboratory data warehouse, is you have to connect it to the plans. You have to connect it to registration and billing. Because until you know how your data walks back to the quality metrics for any given health plan, you can't deliver the value of your data to your payer stakeholders. And from your payers comes the ranking of your health system, which is of critical value to your health system stakeholders. It's not just clinical writ large. You've got to map it out to the plans. The health system, because of this crazy kaleidoscope of internal platforms that our health system has, and since we are the founders of the downstate health information exchange, our ground truth for patient care is actually the external health information exchange, and we actually are the host and monitors of that HIE. The problem is the HIE is not designed for population health. The analytics for pop health don't go through the HIE. You can look up individual patients, but you can't work that data at the population level. So our truth is the laboratory data warehouse, and most recently we've added a pharmacist, a full-time doctoral pharmacist to our laboratory service line to make this connection with pharmacy throughout the health system so that we can ensure that our information is mapped in a timely fashion to intervention and reconciliation at the pharmacy level. And she's been on the job 12 weeks, and she's already doing a fantastic job. So yes, we pay attention to business analytics, we pay a lot of attention to clinical analytics, and to do patient outcomes, and it's still early days, we require data pulls from the electronic data warehouse or the health information exchange. One of my favorite cartoons is from a 1924 comic book that was on my grandfather's, the other grandfather's bookcase, describing a junior cowpoke who had thrown a lasso too generously in the weeds, and the old fella is saying, Wes, if you could learn to use a lot smaller loop in the weeds, you wouldn't have to do so much peeling to get into the fruit. To me, this is informatics. You have to prioritize. You can get, and a military term is overtaken by events, OBE. And we use this term a lot. You can think you've got a prioritized project, but then something comes along and it just blows your priorities out of the water and you get sidetracked and you're not accomplishing what you need to do. It is really important to prioritize. So this is what we've prioritized. For HEDIS reporting, what payers are currently getting from our fragmented market, including the commercial version of fragmentation, is data streams from separate sources which are not uniform. What we have put tremendous effort into, and this was 2015-16, is uniting these data streams from all of our health system sites, and then through a generous, I'm being generous, we don't have EMPI, we don't have Electronic Master Patient Index, but we sort of cobble it together so that we can deliver to the payers the metrics ourselves rather than commercials. For HEDIS, value-based payment and pay for performance, and moreover, we can equip our managed care people with our own data so that they know what the payers are seeing. I commend this, or more anything the CMS puts out for the risk adjustment methodology now in the ambulatory health space, which previously was not risk adjusted, but it is now. It's a zero-sum game. Basically, for you as a provider system, your ambulatory documentation and coding of what are called hierarchical condition categories determine whether your attributed population of patients is deemed sicker than someone else's. And it's, if your competition is doing a better job than you, you will be transferring your premium dollars to that competition, no matter how much the cost of your care delivery was. And I can tell you, academic health systems and the providers in them are currently lousy at doing that. Certainly our people are lousy. And the private folks literally across the parking lot are 6 standard deviations better than us. 6 standard deviations. And so we as a health system and laboratory along the way have learned a heck of a lot about HCCs in the last year. And the most common among any number is diabetes. And if you document once a year that your patient has diabetes, and these are the HCC codes that go with it, it's actually not savings. It's your premium, your enhanced premium value is $470 per month, which means that you are worth $5,645 more in the exchange per year for having documented that your patient has diabetes. At the top of the list is hemophilia. If you document someone has hemophilia, that's worth $196,000 to you that year. What we found as a laboratory is that there is failure to document patients with active cancer, active diabetes, and other active diseases of substantial financial impact to the tune of about $20 million in our health system, just on our risk portfolio in our insurance company. And so for the Care Connect insurance company, which was founded in 2015 and had a large increase in patients previously unknown to us thanks to the collapse of a competitor risk program in our neighborhood, we picked up 60,000 new patients that we didn't know anything about, and they didn't know anything about us. They signed up for Northwell. They had no idea who their doctors were, and they never bothered to find out. And in September of 2016, we realized, oh my God, we are at risk of handing $150 million over to United Healthcare because they're documenting their patients, and we don't even know who they are. Now, we knew who about 50,000 of them were, but there were about 10,000 patients that we had no idea who they were and what problems they had. So we ran a lab, in September 2016, we did a lab scrub of these 10,000 unknown patients. We identified 1,400 that had laboratory identified conditions. And by the time the books closed at the end of the year, with an intense effort to sort of bring these patients in and actually get to know them, let alone provide good care, 1,000 patients were brought in, representing 77% of that new catch basin, which was $7 million of potential benefit once the whole risk adjuster game played out. 121 that by year end were targeted, and lab had 211, or 15% of that lab identified group that remained to be worked. So in the end, for what was attributable to lab, because the health insurance company said we probably would have seen the others by other mechanisms. So there was $2.3 million on the table at year end that was attributable to lab but not yet realized. And when all was said and done, working these data, because once year at the end you can't bring the patient in anymore, but there are compliant ways to make sure that you at least get credit for these patients. There was about it was precisely $607,000 that were brought in as part of a mitigation effort that dropped our risk from $150 million to $134 million. We still paid $134 million to United. But of that $16 million that we mitigated, 0.6 was lab. That was the changing moment for our pathology informatics, where the health system said, okay, we're going to let you in the treehouse. We want you to be part of our risk management effort. So for 2017, the story's yet to play out. Our insurance company is underpowered to do this. We're actually closing it because we can't continue to give $100 million plus to United. But this was our baptism. as a laboratory informatics group in the economics of risk-based care. So with the closure of the insurance company, literally in 3 weeks, we are now being tasked with supporting the ambulatory network shared risk pool for 600,000 patients with the dollars that are in play for these HCC conditions, using laboratory data on the basis of our outreach network. So to sort of bring this home, we are informing population health management for these risk activities. Because of our outreach, we already know these patients. They may be new in the attributed product, but chances are your lab already knows these patients. So the instant patients sign up, scrub the sign up, see who you know. Identify those members immediately to your plan. Determine what lab data is already known and form the plan of pre-existing conditions so that they can start working them in January, not in September. Track the lab data prospectively, work with the plan to provide coordinated care over the course of the year, identify care gaps, inform your plan of the opportunity, and monitor the outcomes. So let's move on to the HEDIS measures and pay for performance. At least in our market, and I think that's true everywhere, HEDIS is not a health system-based metric. HEDIS is sliced very fine by site. So if there are attributed diabetic patients to a single site, it may only be 200. And if you're not doing HbA1c and microalbumin on those patients, and you miss 5, that's a difference between a 3-star and a 2-star rating. And so when we run the numbers, for example, if there are 244 patients for one of our smaller hospitals that have attributed lives, the difference between 207 and 231 getting their HbA1c is a difference between a 2 versus a 5 rating. And when you add that all up on a per member per month basis and multiply by the 600,000 covered lives, you get real numbers. So my back of the envelope calculation, and I intentionally ascribe this only to myself, is that in our HEDIS value-based payment pay for performance part of the system, there are about $2 million directly at risk per year for pay for performance, but it's a double down game. You have the pay for performance in the first instance, but then you have the star ratings, which are penalties in your overall Medicare payment to the hospitals, which are anywhere, depending on how conservative or liberal I am, $10 to $100 million at risk to our health system, and the downside penalties we calculate at 28 million, which means there's potentially $40 million addressable market for our laboratory to inform the economics of the value-based payment system. And if we use the Care Connect experience of our health system being powered only to realize 10% of what lab puts in front of them, that's still $4 million. That's what our COO wants us to do in this coming year. HEDIS, value-based payment, HCCs, on top of all the other wonderful things we do. So our outcomes, I outlined these before. We're hitting most, but not all of them. Key themes and lessons to sort of wind this up. You must identify key partners and communicate in their language. You must know their stressors, which are financial and regulatory. Understand both the clinical and financial perspectives of your stakeholders, including consumers. Pay attention to the missives that the government and payers put out, including the 600-plus page CMS thing that came out a few weeks back on the new clinical lab fee schedule. Know your data and data sources, track attributable outcomes to the laboratory contribution, and focus on the other 97% of the lab spend. You're reducing your costs from 3.0 to 2.95% of the dollar. That's what your hospital administrators want you to do. But that's not saving the world. This is saving the world. And I would also submit that you're getting better patient outcomes as a result, but we still have to prove that. So to answer my own questions, it was actually our executive director of the overarching care maintenance organization for our shared risk portfolio, 600,000 lives, who said, now I understand. Laboratory is an essential core competency of a financially successful health system. That's what your stakeholders need to believe. How can we shape the practice of leadership? Through our leadership at the system level. We must write and tell our story. This is not a time to be shy. And I would say, as far as innovation, anything you can think of. I consider it an infinite space, and I do consider it locally specific. What is relevant to Northwell may not be relevant to you. And that's why this project Santa Fe is about examples and illustration, but is not intended to be prescriptive. You have to have clinical champions, and that is your current advantage. Talking points: never let a good crisis go to waste. Be insistent and intrusive. Listen, deliver, and talk. Prioritize, or you will be overtaken by events, and build upon your in-system advantage while you have it. So I would close by saying Clinical Lab 2.0 is about leadership, not followship. And I want to acknowledge some very dedicated and talented people who've both helped make this happen at the Lab 2.0 side in the laboratory, but also some very important clinical champions that have helped us along the way. And in addition to my closing email, I am instructed to make sure that you provide your evaluation for this seminar. So thank you very much. And I am still live, and there's a microphone. Yes, sir.
Thank you for a very challenging and interesting talk, I would say. To move from the lab to the system clearly requires clinical collaboration. Absolutely. And collaborators.
You can't do this alone.
But I think you also implied that, for example, some of the coding issues, for example, for chronic conditions, that the lab would be able to, as I understood it, sort of somehow either directly or indirectly alter coding, which is a huge...
Now, mind you, you have to be careful about the thin ice here.
Yes, that's what I'm asking.
You have to be compliant. This is where the intrusive comes in. For a coding and documentation task force, lab is part of it. We stuck our noses into it. For the ambulatory electronic health record clinical documentation task force, we invited ourselves in. And as far as coding goes, the AKI is actually an important illustration. We initiated the alert, we put it on the floor, we had Chief Medical Officer endorsement of it, and requirement that the rounding occur, no change, January to June 2014. It wasn't until we brought the coding and documentation professionals into it that we had the normal exchange between the providers and the coding and documentation to make sure that that dialogue occurred. We fostered it, but we used an existing mechanism, which is the current dialogue between coders and providers.
And that's part of my question then. So is there a direct communication essentially from the laboratory to the coding folks or to the nurse?
It is through these task forces with task force approved reporting that is at intervals that are relevant. And for neonatal reporting, for AKI, for those two, it's 7 a.m. in the morning daily. For antibiotic stewardship, we're actually going to a live feed. This is not a daily report. It's not even a shift report. We're actually going to a live data stream where there's a daily metric roll-up to make sure that pharmacy gets the roll-up, and then we drive it to coding. But it has to be under the flag of system-based management. And part of that is compliance, but it's also just what works.
Yeah, makes sense. Thank you.
Sounds like the data warehouse lies at the center of much of these initiatives. And I'm wondering if you could say a few words about the evolution of that resource. Did you design it to capture all the data without focused, allowing yourself to then develop the specific questions later on, or did it start as accumulating data just for a small targeted set of questions and then...
When Tyler came to us from Montefiore, he had already set up a similar data warehouse at Montefiore. So we had proof of concept for the value, at least to the laboratory. We're the ones who took it to the system level. The initial build, okay, so two things. John Gilbertson of Mass General has a lovely diagram which talks about EHRs and LISs, which were designed for transactions. They're not designed for analytics. And if we take our Cerner, with 30 million billable tests per year and try to do analytics on it, we're going to bring it to its knees. We can't run the analytics in Cerner. So just for ordinary business operations and quality management of our laboratory, that was sufficient justification for the laboratory data warehouse. But by connecting it to finance, now we could start doing HEDIS. That was 2015. Then with Care Connect, we could start doing the risk-based management. And all along, we're driving one after the other, to the best of our ability to work with clinical champions, the clinical programming such as AKI, clot, and antibiotic stewardship. And we are really going for high signal-to-noise activities right now. We are staffing the longer-term ones like chronic kidney disease, but we're going for the highest return on investment right now, and quite honestly, the highest documentable impact as we do our build. It's still early days.
Do you have any relevant example that applicable to anatomic pathology?
Anatomic pathology. In this space, no. Being an anatomic pathologist, I would like to. I think it's fair to say we are incubating them because right now we're still living in the world of turnaround time and accuracy. But we haven't been able to map AP into, actually no, I'll give you one exception to that. And that's our running, inactive cancer doesn't count in the ambulatory HCC system. Active cancer does. We are identifying patients who have not been seen in a year, or at least have not been documented in a year, despite having active cancer. Active being defined as it is not cured, they are coexisting with it. That's a huge issue. We can't say whether the patients are not getting care because then we get into the leakage issue. If this is a patient who's attributed to you but is out of network, someone else is providing care but you don't know it, you're getting charged for it and you can't document it, which means you're paying on the back end by calling them a normal patient. But we're their lab. We've got their AP data. So yes, there is we sort of got the tail of that tiger in small numbers.
You talked
By
a
the
lot
way,
about...
it's worth almost $1 million to the portfolio. That small tail.
So it's great. You talked a lot about making the case for the value of the lab to the team. Do you have any thoughts about diagnostic management teams or diagnostic
Yeah, and actually
care
this is
teams?
something we talked at some length at the residence level earlier today. Absolutely. DMT is a term that was co-opted in the health system before I arrived. So, I intentionally don't use the term diagnostic management team here because it's not the Northwell term for it. But absolutely, the concept that pathologists provide leadership in a multidisciplinary fashion for specific groups of patients is very much real. And we have converted the hematopathology workup, rule out this, to a DMT, if you want to think of it that way. The blood banking transfusion medicine space is, I would say, enriched in that area. Acute kidney injury, chronic kidney disease, coagulation management, both ambulatory and inpatient, glycemia, therapeutic drug monitoring. These are all things that would fall under the DMT paradigm and what we're currently doing. So yes, it's very viable and credible. Question down front.
You're setting up your data warehouse. Are you dealing with multiple electronic medical records, or is everybody Cerner, or do you have multiple platforms?
Well, it's a matter of legacy because our enterprise platform is Sunrise Clinical Manager, which is an Allscripts product. Despite the fact that Allscripts is both ambulatory and inpatient, it doesn't; those two systems don't talk to each other. So hence the reason to map it through the HIE at the system level. Every legacy hospital, every hospital we bring into the system brings in its legacy EHR, which gets on a multi-year plan, usually 1 to 3 years before we convert. So that there's always sort of a tail of different EHRs. Moreover, in the physician ambulatory practice, we service over 20 different EHRs, all in the name of the ambulatory version of HCCs and care coordination. So we have to be able to be promiscuous in pulling data into the EHR. Just in the last 3 weeks, we've imported the real-time feed from the pharmacy informatics data set. One of the first things we did was set up registration and billing. You'll notice there's no arrow between us and radiology. That's undiscovered country. We've been prioritizing as we go along, and pharmacy has been our next thing. But yes, it's a complex environment. We do nothing in the dark. All of this is under the auspices of the Chief Information Officer, the CMIO, and they know what we're doing, and we bring our data to them. In other words, this is very much a team effort. In essence, what we're doing is creating enhanced value by having an LDW. And the last thing I would say is, particularly for all of you who are involved with the reference laboratory, you can't run a reference laboratory business if you're dependent on the health system LIS. We drive our own, and that's a business statement, and it has the support of the COO because he's the one who benefits from us driving our own LIS, but it's accountable to the CIO.
So we're over time. Thank you. And let's thank our speaker one more time.
Yeah.